Welcome to the Lymphoma Research Foundation's Understanding Stem Cell Transplantation and Graft versus Host Disease webinar. I'm Kendall, and I'll be the moderator for today's call. During today's call, you will hear from an expert speaker, and you will have an opportunity to ask questions. If you have questions during today's presentation, you can ask them at any time in the Q&A box on the webinar. As a reminder, this webinar is being recorded. At the end of the program, a link will appear on your screen. Please follow this link to complete the evaluation of this program and gain certification of attendance. If you are listening by phone, this link will be sent to your email at the end of the webinar. And now, I am pleased to introduce Jessie Brown.
Thank you. And thank you to each of you for taking the time to join us on today's Understanding Stem Cell Transplantation and Graft versus Host Disease webinar. We'd like to thank our sponsor of this webinar, Pharmacyclics and AbbVie Company, and Janssen. Access to expert disease information is so important, and we are thrilled to be able to bring you this educational program. Before I turn it over to Dr. Abedin, I want to share information with you on the Lymphoma Research Foundation. At this time, I'd like to show you a short video that better explains the work that we do in striving to impact patients, caregivers, and healthcare professionals as we work to fight lymphoma.
My name is Juliana Fuller, and I was diagnosed with follicular lymphoma in 2011. The questions that came to my mind at that time were not just about treatment and about survival, but also, how does a young adult face this? And from the very first moment that I was in contact with the Lymphoma Research Foundation, I was so impressed by the professionalism and just the evidence-based information that was given.
For a lymphoma patient, whether it's newly diagnosed or relapsed, the Lymphoma Research Foundation is an invaluable tool. It's a fantastic resource, number one, for patient education, whether it's online videos, online information, access to clinical trials. Patients can also meet other patients with similar shared experiences as well.
When someone contacts the LRF helpline, we provide them with information about the disease itself, including information about the most common lymphoma subtypes, and we have resources that are specific to these, including fact sheets and booklets. We also provide them with information about treatment options, as well as clinical trials, and whatever their needs might be financial assistance or peer support, for example. One of the ways that we connect individuals with the larger lymphoma community is through our Lymphoma Support Network. This is a peer support program where we match patients, survivors, and caregivers with others who have been through a similar experience. We find that there's certainly something to be said about being able to connect with someone who has walked down a similar path and who can share their own experience with that individual.
I will often refer patients to the lymphoma.org website as well as their app. Both of them provides useful information for whether it's the big picture or also aspects and information for the individual patients.
My involvement with the Lymphoma Research Foundation, currently as an ambassador, as an FDA patient representative, and sat on oncologic drug advisory committee panels for lymphoma treatments. It's what I owe to the team that helped cure me. It's what I owe to the lymphoma community.
Even since my diagnosis, there's been so many new treatments out and even changes in recommendation of what frontline therapies should be. To say how LRF has impacted me, it just has been huge. I felt this relief of anxiety.
The resources that the Lymphoma Research Foundation provides to patients are really invaluable. Coming into the foundation allowed me to do what I need to do as a survivor, and that is to support the new patients that we have, to support the mission to eradicate lymphoma and serve those touched by the disease.
I really hope that you will take advantage of some of the great resources and services that the LRF provides. If you have questions regarding what you saw in the video, or if you need information about relevant treatment options and supportive care resources, you can reach out to the Lymphoma Research Foundation through our website at lymphoma.org or by calling our helpline at 1-800-500-9976. We have a wonderful program planned for you today, and I'm honored to introduce you to Dr. Sameem Abedin. Dr. Abedin is a hematologist and medical oncologist at the Cancer Center at Froedtert Hospital. He is also an assistant professor at the Medical College of Wisconsin. Thank you so much, Dr. Abedin, for presenting today. I'll now turn the talk over to you.
Thank you, and good afternoon to everybody listening today. For me, it's truly a pleasure to be able to discuss about stem cell transplant and its complications with everybody that's listening this afternoon. Hopefully this will be an interactive session, and I'm looking forward to spending some time at the end of this talk to answer any questions that may arise during the course of this presentation. So please, if you type in your questions, I understand that we'll be able to look and review through these questions at the end. A little bit about myself. I'm one of the allogeneic stem cell transplant physicians at Froedtert and the Medical College of Wisconsin. Additionally, I specialize in primarily acute leukemias. My areas of interest or clinical research include acute graft versus host disease, biology and treatments, as well as treatments for refractory or relapsed AML. So with that, we'll begin the presentation. The goals for this presentation are essentially to go over the different type of transplants that patients will be offered, discuss why transplants are potentially offered or discussed in the management of the condition that patients are presenting for, either lymphoma or leukemia. We'll discuss how a transplant occurs, where the cells may come from, the different types of donors that are available, and why a certain type of donor is selected. And then we'll finish by discussing complications of transplant and primarily focus that conversation on graft versus host disease. At the end, we'll hopefully have a considerable amount of time to kind of go over any questions that anybody will have. So just to start, what I wanted to do was actually just go over what the bone marrow is. And so the bone marrow is a spongy area within the bones, and it's the primary factory for blood cells. Not all of bone marrow is responsible for making blood cells. There's a particular part of the marrow called the red marrow, which is centrally located within an individual. These bone marrow are responsible for the production of blood cells. And so if you see this figure, essentially the bone marrow that exists within the pelvis, the spine, the ribs, and then the skull, these are the primary areas where blood production is made. A very small amount of blood production does occur outside of the bone marrow in the spleen and in the liver, but mostly the areas that are highlighted in red are the areas where blood is made. Within the red marrow, there are what are called hematopoietic stem cells. So these are not stem cells that can make bones, for instance, or other organs. These are stem cells that are committed to making blood cells. And so these hematopoietic stem cells have taken the first step toward production of either myeloid cells or myeloid-derived cells or lymphoid-derived cells. And so the myeloid-derived cells include red blood cells, which carry oxygen, platelets, which are clotting cells, and certain types of white blood cells responsible for fighting infection, including monocytes and neutrophils, which may commonly be discussed in clinic. As far as the lymphoid stem cells, these include B cells and T cells and natural killer cells. So what a bone marrow transplant is, what that refers to is actually a replacement of the hematopoietic stem cells within the bone marrow. So bone marrow transplant is commonly used as a term to describe this procedure, but you may also hear this procedure referred to as a hematopoietic cell transplant, and that's because we're replacing hematopoietic stem cells, or just a stem cell transplant. And again, this is referring to hematopoietic stem cells and not other sort of stem cells. So next we'll go into indications for transplant. So for the vast majority of individuals, a bone marrow transplant or a hematopoietic cell transplant is indicated for the treatment of a certain type of cancer. That, by and large, is the main reason why a patient is being considered for this procedure. But there are a couple of other reasons why patients are considered for transplant. There are what are called bone marrow failure disorders, in which case the bone marrow is unable to produce blood cells in an adequate fashion. There are certain autoimmune conditions that are actually indications for transplant, and what the transplant offers is a reset of the immune system, which potentially allows for a cure for these autoimmune conditions. So in terms of indications from a cancer standpoint, the majority of cancers that are addressed by a hematopoietic cell transplant are blood cancers. And so in terms of the most common reason a transplant is performed, multiple myeloma tends to be the most common reason, followed by non-Hodgkin's lymphomas, and then afterwards acute leukemias, including AML or ALL, followed by myelodysplastic syndrome or Hodgkin lymphoma. Blood cancers are by and large the main reason why a transplant is indicated or recommended, but actually for some solid tumor cancers, you may see that stem cell transplant is considered. And particularly for testicular cancer in relapse, a stem cell transplant is sometimes considered. Main reason being these cancers tend to be very sensitive to chemotherapy, and a transplant like this allows for very large doses of chemotherapy to be administered to patients with this type of cancer. So then outside of a malignant indication, there are some conditions considered bone marrow failure syndromes. What these syndromes are characterized by is an absence of certain important blood cells required for a patient. So a particular condition that transplant is considered for is aplastic anemia, and what patients present with that condition include a very low red blood cell count, a very low infection-fighting cell count, and potentially a very low platelet count. In that condition, if available treatment is ineffective, or if a patient is young enough and has a good donor, then a bone marrow transplant replacing the stem cells can cause for these blood cells to return to normal and is a potential cure for that condition. These additional conditions are all additionally considered to be bone marrow failure disorders, for which a bone marrow transplant may replace the failed bone marrow with a bone marrow that functions normally, returning the patient back to normal life. So then also, we mentioned certain autoimmune conditions are conditions for which an autologous transplant is typically considered. Usually these are performed on clinical trial, but for a number of refractory patients, this may be considered as standard of care. And these conditions include scleroderma, multiple sclerosis, and at our institution, occasionally very refractory inflammatory bowel disorders, including Crohn's disease and ulcerative colitis. And again, the rationale for this is essentially an immune reset, which allows this otherwise autoimmune condition, which is causing a lot of comorbidity or difficulty, a chance for that to be reset and for that process to potentially go away. So next we will talk about types of transplant. So within transplant, there are two types of transplants that are typically recommended. The first type is an autologous transplant, and this is the most common type of transplant that occurs within the United States. And what an autologous transplant refers to is a procedure where an individual's hematopoietic stem cells are harvested, followed by a high dose of chemotherapy, followed by a return of stem cells back to the donor. So really, when you're thinking about an autologous transplant, the point of it is sometimes there is disease that's sensitive to chemotherapy, but if you were to give the dose of chemotherapy that's optimal, we won't see stem cells return. In other words, we won't see the return of normal blood counts. So an autologous transplant allows for a high dose of chemotherapy to be delivered to potentially eradicate disease, followed by return of stem cells so that blood counts can return to normal after that dose of chemotherapy is given. An allogeneic transplant is the second type of transplant performed. This is typically the transplant that's recommended for patients with an acute leukemia or a myelodysplastic syndrome. And this is a procedure where a different individual or a donor's hematopoietic stem cells are the stem cells that are administered after administration of chemotherapy. So an allogeneic transplant, you can potentially hit disease with high doses of chemotherapy, and that's one way that it can help. But really the other ways that it helps is it can essentially provide somebody else's stem cells that didn't have the underlying condition within it, and additionally a new immune system that could provide what's called a graft versus leukemia or lymphoma effect, essentially a new immune system that can provide a lifelong surveillance system against malignancy in the individual that receives that transplant. So what are the similarities and differences between an auto and an allo? So in terms of an autologous transplant, again, the main reason for proposing such a procedure is to administer high doses of chemotherapy. In the case of multiple myeloma or non-Hodgkin's lymphoma, the commonest indications for which an autologous transplant is proposed, folks that are considered for those procedures are typically individuals who have already demonstrated a response to chemotherapy. So the thinking is if we give a very large dose of chemotherapy, we potentially can improve the chance of clearing out that disease. So in order to allow for that administration of chemotherapy, we collect stem cells before it's given and then return them to the patient. The same concept can be applied for an allogeneic transplant, except a different donor stem cells are given after the high dose of chemotherapy is given. So the reason for doing that, again, is there may be individuals with chemosensitive disease, including lymphomas or leukemias, for which a high dose of chemotherapy can potentially eradicate more disease, and then stem cells are given from a different donor for additional benefits, to replace the bone marrow from which this leukemia arose or lymphoma arose, and to provide this graft versus leukemia effect or graft versus lymphoma effect. Some differences between an autologous and an allogeneic transplant include the fact that for some allogeneic transplants, we do not give high doses of chemotherapy. This tends to be the case for individuals with comorbidities, which mean that they have some sort of medical problem that would make a high dose of chemotherapy unsafe. We also think about giving a reduced intensity conditioning to individuals who are older, for which if high doses of chemotherapy are given, a high chance of complication is likely to occur. So when we're thinking about doing a reduced intensity conditioning transplant, we're not talking about conditioning being reduced to 25% or so. It's still pretty intense. So the chemotherapy that's administered for reduced intensity conditioning can be anywhere in the range of between 50 and 75% of what you would give with a high intensity or a myeloablative transplant. So you're still giving a considerable amount of chemotherapy. What reduced intensity conditioning just refers to is if stem cell transplant were not to be performed, eventually the recipient's stem cells would grow and the blood counts would return. So why do we do that for allogeneic transplant? The reason that we consider it is there are benefits of just receiving somebody else's stem cells. Like we mentioned, the benefit includes replacing the bone marrow where a bone marrow problem occurred, or this graft versus leukemia or lymphoma effect. So then as a result of getting essentially somebody else's stem cells, there are complications that are unique to allogeneic transplant. So graft versus host disease, which we'll discuss later, is a phenomena that's seen when somebody else's immune system is growing within the recipient. That's not typically seen with an autologous transplant. And then this benefit that we mentioned, this graft versus tumor or graft versus leukemia or lymphoma effect, is something that's seen with an allogeneic transplant. So who gets what? So essentially, the majority of individuals with multiple myeloma are being considered for an autologous transplant, and that's because high doses of melphalan, which is the conditioning chemotherapy typically used, has been shown to have a high degree of disease activity in multiple myeloma. Lymphomas are additionally another condition for which autologous transplant is typically recommended. Most often, patients with lymphoma are given some chemotherapy before their transplant, and if it looks like their disease is responding to that chemotherapy, then there's a thought that a higher dose of chemotherapy can potentially clear out the remaining amount of disease. And so that's why an autologous transplant is considered for lymphomas. On the other hand, for leukemias, which typically are bone marrow problems, universally allogeneic transplants are offered for those patients. And the reason is one, you're replacing that bone marrow for which the disease came from. Secondly, that graft versus leukemia effect is particularly important in terms of maintaining a remission in folks with different types of leukemias. So then, just to kind of summarize, multiple myeloma and lymphomas are typically offered autologous transplants, although in patients who have failed an autologous transplant, there is a graft versus lymphoma or myeloma effect for which an allogeneic transplant could subsequently be considered. For leukemias, for which the old bone marrow or the old stem cells may just cause the leukemia to return, typically these patients are not given their own stem cells again, and they're transplanted with a new donor's stem cells. In other words, an allogeneic transplant is always considered for leukemias. These leukemias benefit also from what's considered to be a graft versus leukemia effect. In other words, the new immune system that comes about when somebody else's stem cells are given, this new immune system potentially could fight off any residual leukemia for the remainder of the life of the patient or the recipient. And so for that reason, typically leukemias receive allogeneic transplants. So just to kind of go over one more time, so in terms of which transplants are most commonly done, multiple myeloma and lymphoma both represent more common conditions than leukemias. Along those lines, what you see more often are autologous transplants being performed. And so what you see is, in fact, actually twice as many autologous transplants in the United States are occurring compared to allogeneic transplants. Since some lymphoma or myeloma patients do get an allogeneic transplant, you do still see a fair number of allogeneic transplants, and this typically captures all the patients that have leukemia that are offered transplant as well. So autos are more commonly performed. Allogeneic transplants occur about half as often. Autos are primarily for myeloma patients as well as lymphoma patients. Allos can be for a small subset of myeloma or lymphoma patients, and predominantly are offered in leukemia patients. So then next we'll talk about transplant donor sources. So where do these stem cells come from if an allogeneic transplant or an autologous transplant is performed? So again, an autologous transplant, what that refers to is that the stem cells of the patient are harvested and then re-administered to the patient. So for an auto transplant, the source of the hematopoietic stem cells are the patient itself. In terms of an allogeneic transplant, there are a number of sources for which we can get a suitable donor for this process to occur. And so this is a coordinated process. This is a coordinated process worldwide. And very interestingly, with this coordinated process run through the National Marrow Donor Program, patients that are considered for an allogeneic transplant have an increasingly high number of patients that are potentially donors for them. The registry worldwide actually encompasses about 17 million individuals, and so for that reason, actually, access to an allogeneic transplant is much less of an issue than it previously was. So in terms of where stem cells can come from for an allogeneic transplant, the first place we typically look is the siblings of the individual that's being considered for an allo transplant. Each sibling essentially receives genetic material from the same parents, This genetic material that determines whether a stem cell transplant would be safe comes from chromosome 6. And there's a copy that's inherited from mom, there's a copy that's inherited from dad. Mom and dad each have 2 copies themselves, so generally speaking, each sibling is a 25% chance of being a match to the individual for which a transplant is being performed. And again, just to take another step back, what are we matching? We're basically matching for immune characteristics that each cell in the body expresses, allowing for the immune system not to attach or attack the body. And so these are essentially genes that are found in what are called the HLA region, which is located in chromosome 6. So if we don't have a donor that's a full match, that's a relative, then we go on to this registry. We look for a matched unrelated donor. And the chance of this occurring by race varies, actually, due to the composition of the donor registry. So a Caucasian individual has about an 80% chance of finding a donor. The lowest tends to be either Asians or African Americans, for which there's between a 20 and 40% chance of finding a full match. If not a full match, we can consider a relative who may be a half match. So these would be stem cells from somebody who inherited one half, either dad or mom, but not both. This could also be a child that's considered, or the other way around, or it could be a parent that could be considered. If that's not an option, then actually we are now doing transplants where we don't use a full match, and what we do is we give additional chemotherapy to overcome that barrier. And these transplants are seeming to be increasingly safe as well. And so overall, for an allogeneic transplant, within these different sources, there's nearly a 100% chance now, if somebody is indicated for an allogeneic transplant, that we can find a donor. Okay. So then we'll finish this talk by discussing complications of transplant. So the way that I'll discuss this is I'll discuss complications that occur during each phase of early transplant. And we'll start with complications that occur as a result of conditioning. So what is conditioning again? So when a transplant occurs, the way that we do it is we start by giving chemotherapy that we call conditioning. And so the reason it's called conditioning is the point of this chemotherapy is essentially to get the body ready to receive stem cells. In order to get a body to receive stem cells, we need to do 2 things. One, we need to clear space for these stem cells to land and grow. We also need to bring down the immune system of the recipient of the transplant, of the patient, so that if stem cells are given, the patient's inherent immune system doesn't reject them. And so conditioning conditions the body to not reject new stem cells, and it conditions the body to have space to receive stem cells. And so when conditioning is done, conditioning is typically high doses of chemotherapy. And so if you think about this chemotherapy, what these drugs actually are doing is they're targeting cells that have a high degree of turnover. So the body's bone marrow is the most active part of the body because the body is constantly making blood cells. The body's second most common area of activity is actually the mouth, the intestines, the stomach, the gut. And the reason for that is if you imagine eating something prickly or sharp, what can happen is you scrape some cells off of your mouth or your throat, you scrape some cells in your stomach, there's all this motion of food going through the digestive tract. And as a result of that, this part of the body needs to be regenerating cells on a very consistent basis. Otherwise, you'll develop holes in your mouth or your throat or your intestines. And so this conditioning chemotherapy, because it really just hits cells that are dividing real fast, causes complications often that relate to the mouth or the intestines. And so when people have complications or side effects in the mouth, we call that mucositis. The way that that's manifest is sores that could develop in the mouth, under the tongue, in the cheeks. These tend to be somewhat painful. Sores that develop in the esophagus or the stomach, and so people can develop some sort of pain when swallowing. Or diarrhea, and that's essentially because of the intestines being affected by this chemotherapy. Chemotherapy can cause nausea and vomiting. For chemotherapy. Also, an additional injury could be to the organs because high doses of chemotherapy are given. A particular injury to the liver is a complication called veno-occlusive disorder, or VOD. Generally speaking, some damage can occur to the lungs or the heart, but these are much lower complications seen in the range of 5% or less with most folks that are getting conditioning. So conditioning is something that's given for both autologous or allogeneic transplants. Complications from conditioning can occur with both transplants. The most common complication that most patients will experience is some degree of mucositis, and that again is a sore mouth or a sore throat, soreness while swallowing, or diarrhea. And the degree of mucositis will depend on how high chemotherapy or high dose of a chemotherapy is given. Nausea, vomiting is common, but usually controlled with antiemetics or medications that are given to prevent nausea. Okay. So after conditioning chemotherapy is given, the body is ready now to receive these stem cells. So the immune system has been lowered, the space has been cleared in the bone marrow. So now when these stem cells are administered, they can take hold and they can grow and hopefully form a new immune system. Normal blood counts will return. So stem cell infusion is the next step for a transplant. Stem cell infusion itself actually has some complications associated. Typically these complication rates are very low, under 10%. So complications that can occur with a stem cell infusion include, for an allogeneic transplant, actually an allergic reaction to the stem cells. So it's not the stem cell per se, but there are white blood cells that come along with the stem cells that can stir up the immune system in the patient's body, and so an allergic reaction can occur for that reason. And that's akin to an allergic reaction that you sometimes hear about occurring if a pack of red blood cells are given during a transfusion. There could be an allergic reaction to the preservatives that are used to store stem cells. So once stem cells are collected, they're typically frozen before they're given back. And the way that these stem cells don't die is there's a preservative called DMSO that's given along into the media with the stem cells, and that prevents these stem cells from expanding or shrinking and bursting when they're frozen and then re-thawed prior to transplant. So DMSO is like any other chemical, and a small number of individuals may have an allergic reaction to that chemical. Very rarely, but a complication that's worth mentioning is infection can come along with the stem cell product. Usually stem cell products are cultured after they're collected, and for that reason infections are found. But a small number of individuals, less than 0.01%, can develop an infection from receiving these stem cells, and that's similar to the risks that occur with a blood transfusion if that's necessary. So the next phase of transplant is, now that the stem cells are given, what we're hoping for is something called engraftment. So engraftment is essentially these stem cells taking hold in the bone marrow and these stem cells starting to grow. What we hope to see after these stem cells are given is in about 12 to 14 days evidence of stem cell growth. And what that looks like on blood work is a white blood cell count that's very low starting to increase. So typically after chemotherapy, blood counts are very low. Transfusions are often given. So for engraftment, what we're hoping to see is that need to give red blood cells and platelets start to go away, and that immune system that's wiped out because of the conditioning, we start to see that return. So white blood cells coming back into the circulation, returning to normal range. So prior to engraftment, if you can imagine that there's really a wiped out immune system, there's a considerable risk for infection. These tend to be bacterial infections. Somewhere in the range of about 20 to 30% of patients develop an infection that's treated by antibiotics. When engraftment occurs, there's a particular complication called Engraftment Syndrome. And what that is if you can imagine the body, there's some injury that occurred as a result of receiving chemotherapy. This immune system, in addition to fighting infection, it's very interested in healing up the body where injury took place. And so when this immune system is rushing back to the body, it could be stimulated by all these areas of injury, inflammation from the chemo, to be hyperactive. And so sometimes when these cells are coming back, a fever occurs, shortness of breath occurs, and that's called Engraftment Syndrome. Essentially, this immune system rushing back trying to solve a problem, that occurred as a result of the chemotherapy. Steroids can be given. Usually Engraftment Syndrome is very easy to manage with steroids if it becomes severe enough. So then after engraftment has occurred, essentially this immune system is new. So, if you imagine your immune system before transplant, it's seen a lot of infections, it's diverse, it has a lot of different immune cells that can fight a lot of different infections, but you're starting from square one when these cells are coming back. So there isn't, diversity in different immune-fighting cells. So for the next year or so after transplant, this immune system is growing back. And as a result of that, there is a risk of infection that, that exists because of going through this transplant process. And that infection risk diminishes as this new immune system diversifies, is able to, identify different infections, and it grows into the body that, that it's growing into. For allogeneic, and this is a risk that exists for both autologous and allogeneic transplants. Particularly for allogeneic transplants, there's a particular complication called graft versus host disease, and that's something that we'll finish this talk with by discussing and kind of going over what it looks like and how to treat. So graft versus host disease, first of all, is something that occurs in patients that receive another individual's stem cell, so only in allogeneic transplants. At its most basic form, what graft versus host disease represents is new immune system, the graft, attacking new body, which is the host. When we talk about graft versus host disease, there's actually two forms of graft versus host disease. There's graft versus host that we see within the first 100 days, and that's called acute graft versus host disease. There's graft versus host disease that can occur generally after 100 days, most commonly between 6 months and 2 years, and that's chronic graft versus host disease. In terms of how often GVH occurs, it depends. It depends on whether the stem cells that are given are from a direct relative or not. It depends on if big chemotherapy or myeloablative chemotherapy is given or not. And so for folks who receive very closely matched stem cells from a relative, who receive lower doses of chemotherapy, acute graft versus host disease occurs in the range of about 30% of the time. For individuals who receive unmatched or unrelated stem cells and receive a high dose of chemotherapy, up to 50% of those patients can develop acute graft versus host disease. From the standpoint of chronic, so depending on the type of stem cells that are given, depending on the intensity of chemotherapy that's given, this can occur between 15 and 60% of the time. So there is a big range in terms of what the risk of graft versus host disease potentially is. How does it occur? So why does graft versus host disease set in? Classically, graft versus host disease is thought to set in due to a three-step process. So the first step, or the main reason why conditioning intensity matters, is what happens before the new stem cells start to grow is the body takes a hit. If we're giving a big dose of chemotherapy, we mentioned the complications associated with that, mucositis, nausea, vomiting. Really, this is the end result of big doses of chemotherapy causing injury within the body. So this injury within the body stirs up the body, and it essentially makes the body inflamed. And as a result of this inflammation, when these stem cells start to produce T cells, which are a certain type of immune cell, these injured parts of the body actually set off signals and show sort of characteristics for these T cells to come in and try to heal the problem. Unfortunately, if it does that in the wrong way, what can happen is these T cells are activated more than they should be, and then start attacking that part of the body that's already injured. And so that's the next phase. If the body cannot shut that unnormal or sort of overreaction of T cell activation, the next thing that happens is these T cells and other cells that kind of go to the site of graft versus host disease essentially set off more signals, and then essentially more T cells are activated, and a higher degree of inflammation then occurs in injury. And these three steps is why acute graft versus host disease ultimately develops. How does it look? So essentially, acute graft versus host disease typically affects three major organ systems, so the skin, the GI tract, and the liver. For the skin, what's visually apparent when graft versus host disease acute GVH is occurring is what's called a maculopapular, which means a bumpy red rash. And so this image right here sort of gives an example of what a patient can manifest when GVH of the skin is occurring. And what we do is we see how much of the skin is involved. We see if any skin sloughing occurs, and that's how we can basically tell if it's a big problem or a less severe problem. Graft versus host disease can attack the GI tract, and it can attack both what we consider to be the upper GI tract, which is mouth, esophagus, stomach, or the lower GI tract, which is intestines. And so if it affects the stomach and the mouth and the esophagus, how that manifests is the development of nausea and then anorexia. In other words, really no desire to eat. And so we're very carefully watching whether patients are losing weight, losing interest in eating, and are feeling nauseous. That could be a sign of upper GI GVH, and certainly something that we would try to address, because certainly if weight is being lost, fluids aren't being taken, that can cause bigger problems within the individual that received the transplant. Lower GI GVH manifests as cramping, so really persistent bad cramping that can be painful, along with diarrhea. And so lower GI GVH we quantify by seeing how much diarrhea a patient is experiencing. It can be mild, 3 to 4 episodes of diarrhea a day. It can be severe, greater than 10 to 15 episodes of diarrhea a day. The way that I like to sort of figure out whether whether diarrhea could be GVH is what you tend to see is diarrhea that's GVH related tends to wake up a patient at night, to have a bowel movement. Usually when you've had an infection or, another sort of problem that leads to diarrhea, it tends to calm down at night. But GI GVH is a relentless sort of inflammatory process within the bowels. So that's typically the first question I ask when somebody is coming in with diarrhea within the first 100 days of transplant. So lastly, GVH can affect the liver acutely within the first 100 days. This is usually manifest in blood work. So we typically get blood work weekly or twice a week within a patient that's been transplanted. We look for rises in certain blood levels. The bilirubin is typically elevated for acute GVH of the liver. But then for severe issues with liver GVH, patients can actually report pain over the liver, weight gain, and that's due to fluid accumulating around the liver, and jaundice, which is sort of a yellowing of the eyes and skin. So in terms of what happens once GVH is identified, we try to identify it as quickly as possible, and we administer steroids. And so steroids are a very broad immunosuppressive medication that can kill off lymphocytes, B cells, are not really targeted sort of interventions. And steroids tend to be actually fairly effective in terms of mitigating graft versus host disease. So nearly 65% of the time, if steroids are given in a prompt fashion, acute GVH comes under control. In the 35% where steroids are given and we don't see any improvement either in rash or diarrhea or whatever the manifestation is, we recently have had an approval of a medication. So previously there were no sort of established second-line options, but approval of this drug called ruxolitinib, which is an anti-inflammatory medicine. And in the situation of where this is added to steroids, nearly 60% of patients who initially don't respond to steroids subsequently respond when ruxolitinib is given. So most patients now with acute GVH are able to have an improvement in that problem if it's identified and treated. So it's increasingly becoming a complication for which there's less mortality or significant morbidity risks. So we'll shift to chronic GVH. Again, this is graft versus host disease that's seen after the initial few months post-transplant. And it looks different, actually, than acute GVH. So first of all, why does it occur? So one reason that chronic GVH can occur is residual inflammation, actually. So for folks that got a higher intensity chemotherapy, those folks are at a higher risk of having chronic graft versus host disease just because the body still hasn't healed up all the way from the conditioning that was given. There could be residual inflammation from actually acute graft versus host disease. That's another reason why chronic can sometimes develop. So inflammation that causes stimulation of this, persistent stimulation of the immune system is thought to lead to chronic graft versus host disease. Another reason that chronic graft versus host disease can develop is there is a process of tolerance that essentially should be occurring after an allogeneic transplant occurs. And what that means is this new immune system that's growing through the body should be looking at this body, and parts of the body, including the thymus, which is an organ that's located above the heart, lymph nodes, the spleen, all these parts of the body, what they're doing is they're finding white blood cells that don't like the body and trying to eliminate them. And slowly in time, the immune system that's growing into the body is essentially being shaped in a way that that is such that it doesn't attack the body long term. Unfortunately, due to either injury of these training grounds or basically because these training grounds don't work as well anymore, there could be some persistent T cells, particularly, that are still prone or wanting to attack the host that it's growing in. And so for that reason, that's another reason why chronic graft versus host disease can develop. These T cells can then stimulate B cells, which are antibody-producing cells, to produce antibodies that attack actually parts of the body, including the skin. So that's sort of a process that can lead to chronic graft versus host disease. Ultimately, these immune cells can activate a third type of immune cell called macrophages, and these cells actually then can cause a process called fibrosis or scarring, which is a key characteristic of chronic graft versus host disease. So what does chronic graft versus host disease look like? So unlike acute graft versus host disease, where skin, GI tract, liver are the common sites of manifestation, for chronic, actually the mouth, the eyes are the most common areas that you see it. So mouth, what patients complain of is dry mouth. Actually, the way that most patients describe it is, it becomes very difficult to eat dry foods like bread, actually. Chronic ocular GVH is common, but what that sort of feels like is the sensation of sand actually in the eyes. The sensation that opening the eyes causes pain, and closing the eyes feels better. So that's the second most common manifestation. For skin, as opposed to a red, itchy rash, how chronic GVH manifests most commonly is either a lightening or a darkening of the skin, or a thickening of the skin, which is called sclerosis. Musculoskeletal GVH could be muscles that are persistently contracted. Liver GVH is seen as just blood work abnormalities, liver labs that stay high without another reason. And lung GVH, which is rare but can occur, involves the scarring of the airways of the lungs, preventing air from coming in and out of the lungs in a normal fashion. And so the way that you diagnose that is to detect a phenomenon called air trapping, which essentially means if you take a deep breath in, what you're trying to see is all this air then comes out on exhalation. If either on a CT scan or a pulmonary function test you're not seeing all the air come out, that would be a clue that potentially GVH of the lung has set in. So how is chronic GVH treated? So if it's just in the mouth, we try to use steroid rinses or other immunosuppressive rinses. If it's in the eyes alone, we use immunosuppressive eye drops or lubricating eye drops or lubricating prostheses. UV therapy is sometimes effective in loosening up the skin. Sometimes, though, if chronic GVH is bad enough and multiple areas are affected, then we turn to steroids again. So steroids are the first-line treatment for that. Approved treatments otherwise include a drug that you sometimes hear for lymphomas and for CLL, ibrutinib, which seems to have an effect on both B and T cells, which are both involved in the development of chronic GVH, and is particularly helpful for GVH that involves the skin or the mouth. So just to finish off, so what puts patients at risk for GVH? So just to take a step back, we mentioned that some patients are only at a 30% risk of developing acute GVH. Others are at a 50% risk. Some patients are at only a 15% risk for chronic GVH, whereas others are at a 60% risk for developing chronic GVH. And so what are the reasons for that? The reasons that some patients are at a higher risk for development of GVH include receiving higher doses of chemotherapy in the beginning. That causes greater injury to the body, and then that sets up for greater inflammation that can put patients at risk for GVH. The stem cells that actually are given matter. So if stem cells are given from the bone marrow, there's actually a lower risk of GVH compared to if stem cells are harvested from the blood. And the reason for that is actually when you collect stem cells from the blood, you can't fully separate mature white blood cells that also circulate in the blood coming along with the stem cell product. And as a result of that, these stem cells are ready to cause problems as soon as they're administered to the recipient of the transplant. Thirdly, the type of donor that is given matters. So a matched sibling tends to have a much more matched immune system compared to a mismatched unrelated transplant, and so that that determines what the risk of GVH is. There are two emerging reasons for the development of graft versus host disease, which should also be of note. So there's this concept of dysbiosis, which is taking increasing, is picking up increasingly. There's an increasing role of basically the imbalance that's seen in the gut playing a role in graft versus host disease. And then essentially there are different ways now that we are trying to prevent graft versus host disease, and there may be ways that further mitigate the risk of chronic graft versus host disease developing. So taking a step back, what does dysbiosis mean? That means an imbalance of good to bad bacteria in the gut. When you eat yogurt, the reason that yogurt is considered to be so good is it contains good cultures in it. Lactobacillus is a good bacteria to have. And so the thought is if you eat yogurt, it helps that bacteria grow in the gut. There are bad bacteria in the gut. There is a particular strain of bacteria called Enterococci. These bacteria send off inflammatory signals if they grow too much in the gut. As a result of that, they can stimulate graft versus host disease. So if there's an imbalance where there's more of these Enterococcus species as opposed to good bacteria like Lactobacillus, there's a higher tendency for inflammation in graft versus host disease. So what can be done to kind of prevent that? So essentially very judicious use of antibiotics is important right around the time of transplant, because some antibiotics can just wipe out the good bacteria you want and keep the bad bacteria you don't want. Diet actually plays a big role in terms of the balance of bacteria. So essentially, good bacteria like a high fiber environment, and actually good bacteria or bad bacteria thrive on a high lactose environment post-transplant. There are some studies that Enterococcus particularly likes to feed on lactose. And so things that can be done for a patient is, sort of a high fiber diet, or taking lactose or lactate, kind of around the time of transplant to minimize the amount of lactase or lactose that's kind of circulating through the system. In terms of graft versus host disease prophylaxis, a new way to prevent graft versus host disease is giving an additional dose of chemotherapy after the transplant is done. And that additional chemotherapy is this drug called Cytoxan. What that drug does is it particularly targets cells that are about to react to the body. And interestingly, what the end result of that is it potentially wipes out T cells that are about to grow and lay the groundwork for chronic graft versus host disease. So actually, chronic graft versus host disease is seen at a significantly lower rate in folks that receive post-transplant cyclophosphamide, as low as about 15%. And so this is sort of an emerging area. If chronic graft versus host disease is considered to be a huge problem for a patient, giving this type of way of preventing graft versus host disease is increasingly being considered. So just to conclude, a bone marrow transplant is a procedure where hematopoietic stem cells are administered to replace the existing bone marrow. It may offer the best chance of cure for a number of blood cancers, and that's why it may be offered. And within an allogeneic transplant, there is a particular complication we focus on, graft versus host disease. And so this should be something that's discussed with the transplant physician before transplant to figure out best ways of kind of mitigating that after a transplant occurs. Okay. So with that, we'll kind of move on to the questions. And so I see these questions below, and I'll start to just kind of.
We actually have some already pulled up here if you want me to just read a couple of them out for you, Dr. Abedin, if that works.
Yeah, absolutely.
Okay, great. Perfect. And just before we begin, are you okay in terms of your schedule if we maybe go 10 minutes over the end time?
Yeah, that's fine.
Okay. All right, great. So the first question is from online, and it is, does age influence the potential success of stem cell transplant? Is there a cutoff for eligibility?
So in terms of age, so where age plays a role is essentially along with age comes comorbidities. So first of all, there isn't a hard upper age limit to consider transplant, although most institutions above the age of 70 to 75 start to consider whether it's, there's more risk to benefit. So, so essentially on a case-by-case basis, an individual that's over 75 could be considered for transplant. But with age, what really comes along is an increased risk for, potential heart disease, an increased risk for potential dysfunction of the liver or the lungs. And so for those reasons, really what we try to figure out with an older individual is if this older individual were to develop a complication like an infection or graft versus host disease, do they have the wherewithal to kind of weather the storm? And so in my practice, certainly I've transplanted individuals up to the age of 78 years old, but those patients tend to be individuals that are very active, extremely physically fit, no heart issues, no lung issues, and a great support system. And so, those are really the things you really try to hammer down when somebody is older. And if really favorable features exist, then you still think about transplant because of its potential role for cure.
Great. Thank you so much. Our next question is a two-part question as well, and it is, on average, how long does a stem cell transplant last before relapse occurs, and can a second transplant take place, and if not, what are the alternatives?
So that really depends on the disease that is essentially being transplanted. And there are a lot of alternatives, and second transplant is actually a consideration as well. So generally speaking, if a autologous transplant is performed for multiple myeloma or an autologous transplant is performed for lymphoma, there is a proportion of patients that relapse occurs, and so that proportion of patients can be anywhere between 40 and 60%, and that typically happens a couple years after the transplant is performed. So that means the remaining patients remain in remission after an autologous transplant. In the case of an allogeneic transplant, if offered, generally speaking, for myeloma and lymphoma, the chance for cure in that situation is in the range of about 40%. And so for those individuals, there's a 60% chance, typically within the first 2 years, that this disease returns. For leukemias, which are only offered allogeneic transplants, the risk of relapse ranges anywhere between 30 and 70%. So there's a 70% to 30% chance of cure, which means that there is, that percent of a chance that, further treatment is required. In lymphomas and myelomas, actually the field is, really pushing forward in terms of new treatments to kind of help these patients. So CAR T-cell therapy, which is another type of cellular procedure, is increasingly taking foothold and may offer cures in individuals that have relapsed after transplant. Second transplant could be considered. Say that somebody has a really long duration of response after transplant. These individuals probably have built up their strength again, are healthy enough where something big could be given. These patients probably have disease for which that chemotherapy responded or worked for a long time. So in a situation where somebody, say, 4 or 5 years after a transplant, sees some of their disease return, a second transplant could be considered in that situation.
Great, thank you so much. Our next question from online is, if a sibling that you are considering using as a donor is an identical twin, is chromosome 6 still relevant?
Yeah, so we still confirm that the patient's sibling is an identical twin, but if that were the case, then they'll have an identical chromosome 6. So as a result of that, when we do typing, we'll find no discrepancy.
Okay. Our next question is, are there any good blood tests that can predict high risk versus low risk for GVHD?
So GVH in terms of risk is really mostly determined on how matched the immune system is to the individual. So as opposed to blood type, the factors that really matter is what we do is an additional type of typing process called HLA typing. And this really looks at essentially these identifying characteristics that exist on the skin, in the gut, in the mouth of the recipient cells. So the patient, each of their cells has these projections on them that say, hey, I'm a part of this body. So when we do HLA typing, what we look at are basically, with this new immune system, am I going to like or am I going to dislike these features that the mouth, that the gut, that the skin is projecting? And so when we do that typing, that's really the reason that we do it. We try to find sort of an immune system that if it sees that body is generally going to be, unstimulated, by that body's characteristics. Other things that seem to matter is if a female set of stem cells are given to a male, that sort of difference seems to increase the risk of graft versus host disease. And so those are kind of considerations that are also sort of looked at.
Our next question is, I have just completed a stem cell transplant. Do you recommend I should eat certain things and avoid others like lactose?
Yeah, so, this is all sort of emerging. So essentially, there are sort of increasing studies, and these are studies that are coming out of Duke, Memorial Sloan Kettering, which show that individuals that have a high biofiber diet, so these are essentially non-digestible fibers in foods, promote the gut promote the gut to grow good bacteria. And so, what's now known is there are certain types of bacteria, if they kind of grow in your gut, they just kind of cause this sort of constant inflammation. And this constant inflammation then leads to increased rates of acute graft versus host disease and actually increased rates of chronic graft versus host disease because this immune system is constantly being stimulated by these sort of undesired bacteria. And so for that reason, there is sort of a recommendation of kind of increasing biofiber or non-digestible fiber in the diets of individuals that are getting transplanted. Immediately after transplant, I think it's a hard ask. I think really with mucositis and all the other sort of issues, we really just want the patient to eat. But if they are able to get fiber in, it's very helpful. In terms of lactose intake, so certainly, there are benefits of eating cheeses and milk. A lot of times, actually, that's really the only thing that my patients are able to taste and tolerate, particularly early after transplant. There have been some studies actually where patients take lactate, which is an over-the-counter supplement that breaks down the sugar lactose. And those patients tend to have less of that Enterococcus species bacteria in their gut, the bad type of bacteria that could lead to inflammation and graft versus host disease. So there hasn't been a direct connection between taking lactate or avoiding dairy and less GVH, but they've sampled the gut bacteria of individuals who have taken, either a low lactose diet or lactate, and they find less of the bacteria you don't want in their gut. So there's an indirect sort of thought that may actually help sort of prevent the risks of acute and chronic graft versus host disease.
Thank you. I think we have time for a couple more questions. This one asks, I've had 2 stem cell transplants, and after the second developed chronic GVD, mainly on skin and lower legs. Doctors have tried steroids. Are there any other treatments available?
There are, yeah. So in terms of chronic GVH of the skin, so there are a number of treatments that are considered, if steroids don't work. So depending on sort of the type of issue that's going on with the skin, if it's really a thickening of the skin, what we call sclerotic features, 2 things that are considered are UV therapy, so PUVA is what we call it, or a treatment called ECP, which is extracorporeal photophoresis, and that's really a combination of UV light and manipulation of white blood cells to essentially make the white blood cells attack the skin less. Ibrutinib, as we mentioned, particularly had effects for individuals with skin GVH. There's a medication that recently was approved for chronic steroid refractory acute GVH, ruxolitinib, which is showing really very encouraging results for GVH of the skin that's chronic as well. And so because that medication is approved now for steroid refractory acute GVH, some clinicians are considering that medication for chronic GVH as well, and that's a discussion that you can have with your transplant physician. So there are a number of options that could be considered. What I usually take into account is if the patient is close by to me or not. That dictates whether I can give or refer them to UV light therapy or ECP. If they're further away, then pills are much more portable, so then I would think about something that way to try to mitigate the issue.
Thank you so much. And this will be our last question of the day. Will I always be on anti-rejection medication after my stem cell transplant?
No. So essentially, the hope is with this transplant that tolerance, essentially the process for which the new immune system and the body reach some sort of homeostasis. So when a transplant occurs, at first there's a tremendous risk for graft versus host disease. This new immune system is in the body for the first time. The body is inflamed, and the new immune system doesn't particularly know which part of the body to like and which part of the body not to like. So that's why immune suppression at full doses is typically given early on post-transplant. But then in time, what happens is, this new immune system gets to circulate through the body. So there are parts of the body that express what are called antigens, which are sort of identifying features of the host. And what happens in these areas is the types of immune cells that don't like the host, these cells are eliminated. And so this is the thymus, these are the lymph nodes, this is the spleen. So as the blood circulates through these parts of the body, the not so good white blood cells are eliminated. So actually about 3 months after a transplant is performed, so around 90 days, if there is no evidence of graft versus host disease so far, most individuals begin a taper of their immune suppression. And so what that means is we just challenge the body with less immune suppression to see if any graft versus host disease arise. That taper typically is a process that occurs between 2 and 3 months. We slowly decrease the amount of immune suppression that's being administered, and at the end of the taper, somewhere in the range of about 50% of patients are able to come off immune suppression at the 6-month mark. For the 50% that aren't, You just give it longer to basically allow for whatever graft versus host disease was causing, the requirement for immune suppression. And then, if it's a few months after that, there's no evidence of GVH, then a taper can occur so that, these medications are off at 9 months or 12 months. If chronic GVH, appears, we still try to take patients off of immune suppression once chronic GVH is controlled. And so for those patients, maybe an extended period of time, but hopefully by a year and a half, 2 years, immune suppression is taken off. So, but for 50% of patients, actually by 6 months, there's no longer a requirement for any sort of immune suppressive medications. For the other 50%, it may take an additional 3 to 12 months to kind of get a patient off of immune suppression.
Wonderful. Well, thank you so much, Dr. Abedin, for joining us today on this talk, which was really informative and comprehensive. I know everyone who was on it today really appreciated you speaking on this important topic. So I'd just like to thank you first.
No, thank you for having me. Again, it's a pleasure to answer these questions and to provide this information. And certainly for everybody that's listening, particularly if they are potentially being considered for a transplant, I wish them the best of luck and hope that, the best outcomes come about it.
Thank you. And we'd also like to thank our sponsor again for making this program possible, Pharmacyclics, an AbbVie company, and Janssen Biotech. Please remember, if you have any additional questions or you'd like to be connected with someone else who has been impacted by lymphoma, you can reach out to the LRF helpline at 800-500-9976. Also, at the conclusion of this program, you'll receive an email prompting you to complete a program evaluation. I ask that you just please take a few moments to complete this, as they are really important for helping us to ensure that they deliver the most useful and meaningful programming. And with that, I'd like to thank all of you for joining us and hope you have a wonderful day.